And that brings us to our presentation, why you're here this morning. We are going to discuss electrical stimulation from the perspective of the current evidence and what is it telling us about the practices we've been using. Should we continue with the same strategies, or do we need to make some modifications to be most effective? So we will take a look at that. To tell you a little bit about myself, I mentioned my name is Jody Gutkin. I am a physical therapist. I have been practicing for 25 years and loved every moment of it. I will try to bring in examples as I speak from all the different practice settings that I've worked in. I have worked in the continuum of care. I've completed acute care in the ICU, the NICU, general medical, total joint, acute care experience. I have been a physical therapy supervisor of an inpatient rehab unit in a teaching hospital where we worked closely with physiatrists, rehabbing patients with neurological insults, CVA, head injury, spinal cord injury, amputation. I've also enjoyed the outpatient setting, doing orthopedic rehab, both pediatric and adult. Rounding things out in pediatrics, I've had the opportunity to practice in pediatric home care as well as the school setting, completing IEP evaluations, and I moved to Florida. So I added to my repertoire and experience working in the skilled nursing setting. And then in my second life as a therapist, I have been an physical therapy educator for many years. So I hold a master's degree in education also. And I look forward to imparting my different experiences with all of you. I know we have both PTs and OTs in attendance, so I will be able to pull examples that'll work well for all of us. So I look forward to those discussions. What we're going to look at today specifically related to electrical stimulation is going to be a little bit of a review of the contraindication, putting a slant of current evidence and going a little more in depth. What are those medical situations where we shouldn't be utilizing electrical stimulation? And then we will spend some time looking at the physiologic effects, because I really feel that understanding the physiology and what's going on beneath the surface of the skin is what allows us to be stronger clinicians, particularly with modalities, because we're going to be critically thinking and analyzing. We're not just pushing a button, preset one, slapping some pads on, and billing for it. That there's a lot we're going to talk about. So we'll revisit that A&P back from school a little bit, but in a clinically applicable way. And then we will also look at all the various parameters and settings that you're going to utilize to maximize your electrical stimulation interventions based on the impairment that you're going to use. So this is one of those topics where you may have some time during it where you're just like, yes, that's what I'm doing. Great. I don't think there's anything wrong with taking a continuing education class that says the current research reaffirms what we're doing. I think we should double check that also. I also think you'll find you'll walk away with a stronger knowledge of why it's working, as well as some different ways to modify your interventions to be even more effective, and maybe apply them to different patient populations. As with any course that you attend, when you go back in the clinic to apply these techniques, you're going to do so in accordance with the practice guidelines of the federal, state, and professional organizations where you practice. And here's our specific schedule for today. Our first hour will be looking at the contraindications and physiologic effects. In the second hour, we'll go over those specific parameters or settings for the unit. And then in our third hour, we'll look at your electrode setup and then some safety considerations that you should have when you're applying your electrical stimulation. So to begin our content discussion, I mentioned we're talking about electrical stimulation, but that is such a huge topic. There are so many different types of current that we can be reviewing. So we needed to scale it down a little bit. So we're going to specifically be focusing on alternating current. And these are just a couple of the pieces of equipment that you may see in your clinic that could deliver eStim. And again, there's so many different ways that we can accomplish that. So we are going to slim that down. To give you an idea of where the information comes from for the course is that it is all based on research. This is not just my opinion. I go through and I read many, many research studies, not only from our physical therapy journals, but also from journals of neuroengineering are actually very interested in electrical stimulation and its effects. There's an International Electrophysiologic Society, many of the biology journals, because we'll look at the physiologic impact of the current on the cells. They had some great research studies. And there's studies which are international also. We're not only looking at research from the United States, just from our physical and occupational and athletic training journals. So you'll get a nice cross section. Those of you that are interested in the research like I am, and you might want to dig into these studies a little bit more, on the last several slides of the PowerPoint presentation that you have, I have all the references included in there, so you can go back and take a look at those. I usually use studies that are out there for free so that you can readily obtain them to peruse a little more deeply if you would like. The specific type of current that we are going to look at today is alternating or biphasic. This is our waveform where we are going to have that sinusoidal wave that has both a positive as well as a negative aspect to it. So essentially that current is flipping between a positive and a negative aspect as it transmits through the patient between the two electrodes. When you're looking at your pieces of equipment, because I think it's important to understand practically, okay, when you get back into your clinic, how do you apply what we talked about today? Many of the units are going to label the waveform biphasic. Others may just show you the waveform, so that would be that sinusoidal waveform that you're going to look at so that you know how to apply this type of current on your equipment. We're going to utilize many different types of equipment to accomplish this. And again, each unit may be a little bit different in how they communicate that to you, but the idea is that alternating current, biphasic, symmetrical, all of those are the same, essentially the same waveform that will elicit all of the effects that we are discussing today. So in addition to your large electrical stimulation units that you plug in, there are sometimes portable small units that you may be using that are also an alternating current, an NMES type of unit. An NMES is our clinical terminology that we are utilizing, which stands for neuromuscular electrical stimulation. And this is typically what you're going to document when you're applying this type of current, because it clarifies to other clinicians as well as ourselves for our documentation that it is stimulating the nerve in order to stimulate the muscle. So we need to have an intact neuromuscular junction and nerve to muscle connection, because this current, when we apply the electrodes to the skin, is going to depolarize the nerve, send the acetylcholine across the neuromuscular junction, and then it's going to stimulate the muscle contraction. So in that sense, it follows our normal excitation and our normal conduction, where we are cognitively thinking of contracting, my wrist extensors. So we're going to depolarize that nerve to elicit the contraction. Neuromuscular electrical stimulation will also depolarize the nerve to initiate the muscle contraction. In doing so, we have the ability to manage several different impairments for our patients. We can manage edema effectively by stimulating a muscle pump to help milk out that edema, increase the lymphatic return also to milk that edema out. We can manage muscle spasm by stimulating a muscle contraction in order to fatigue out that muscle, allowing it to relax for increased range of motion. And then muscle weakness is where we're really going to see some of the greatest benefits from neuromuscular electrical stimulation. Sometimes we'll refer to that as muscle re-education, where we're reteaching the patient how to recruit the muscle, or muscle strengthening. If you're performing a specific functional task, for example, as your patient is ambulating, you have electrical stimulation on them, which elicits dorsiflexion during the swing phase of gait, then that would be termed functional electrical stimulation because the E-stim is contracting the muscle during their functional task. So another way that this same current can be applied. The other populations beyond your orthopedic population that I want you to consider this current to be utilized for is your neurologic population. That many individuals who have sustained a stroke or children with cerebral palsy where they have increase in tone, we can utilize electrical stimulation to influence that and increase the ability of the higher cortical centers to respond through our electrical stimulation also. So when we get into these physiologic effects and benefits, don't only be narrow-minded with orthopedics. There are many applications that are also beneficial for our various neurological populations. We first need to know who not to use our electrical stimulation with. And it's important to recognize the contraindication. And this is always something in school when you're learning about the electrical stimulation. Well, you know, yes, when to use it, when not to use it. And if you pull out 10 different books, for the most part, they're similar on the contraindications, but sometimes there's variability among them. So in an effort to present you with the current information and objective information, we're going to highlight some specific contraindications. It's not an exhaustive list, but it's some that bear a little bit more discussion versus memorization. And this is based on a 2010 study that was completed by Canadian researchers. It was very vast. What they did was they went through research studies, textbooks, all the different resources that they can consider. And they pulled from the United States, Canada, Australia, and the United Kingdom, our large research centers, to compile this information and say, well, if we look at all these different resources, where do they agree on the contraindications for electrical stimulation? And in their ranking of these studies, they said, you know, if there's instances where we can say 86 to 100% of the research agrees this is a contraindication, these are definitely the ones that we should all be staying away from with utilizing electrical stimulation. They also looked at the quality of the evidence, and it had to be at least moderate to high quality evidence for them to include the contraindications on the list for electrical stimulation. Let's take a look at some of those that they highlighted. One of them is placement over the anterior neck or carotid sinus. And this is probably, right, the first one that you memorized back in school. Don't, apply the electrical stimulation pads in this area. Why? The key here is that we have our carotid sinus, and we have our carotid arteries traveling up in that area. We want to be cautious because applying electrical stimulation in that area can potentially stimulate the vagus or the phrenic nerves, which can cause a shift in our stimulation of the heart and heart contraction, blood pressure. So it can cause an alteration and possible cardiac event for the patient that we want to avoid. You should also consider for any patient with a cardiac history, some of the research is indicating that applying electrical stimulation anywhere in the body with someone with a significant cardiac history, for example, they have an arrhythmia. If you stimulate the autonomic nervous system anywhere in the body, you can have a reflexive reaction from the cardiac system where you can alter heart rate. And if they trigger that arrhythmia, then it could possibly lead to a cardiac episode for that patient. So your patients maybe with cardiomyopathy, congestive heart failure, arrhythmia, consider if you have other ways to manage that patient as opposed to assuming that risk of applying electrical stimulation, even if it's to the distal leg, because some of the research is saying if you have any autonomic nervous system stimulation anywhere in the body, you can have a negative cardiac consequence. Also be aware up in this head and neck area, anterior and posterior, that any patients who have a history of seizures with epilepsy, even patients who have had head injury, stroke, cancer, where they're at an increased risk of having a seizure, or seizures may be a consequence of their current diagnosis. You want to be cautious and avoid using electrical stimulation in that area because you could trigger one of those seizures potentially. And one other I wanted to mention also for our occupational therapists, if you're using electrical stimulation for dysphagia with difficulty swallowing, you want to be particularly cautious with your electrode placement in this area and watch that you don't create too significant of a laryngeal spasm that could lead to restriction of breathing for that patient. So be cautious in that neck area if you're working with dysphagia patients. Patients who have in the distal extremities history of a deep vein thrombosis or thrombophlebitis where the clot is still adhered to the inside of the lumen or the blood vessel. When we apply electrical stimulation, it's going to increase circulation in the area. In doing so, you're going to have more blood flow going across the inside of the lumen of the blood vessel, and it could potentially break off that clot. So you want to be cautious that you don't cause an embolism that then can travel to the lungs or the brain or a different region for that patient. Any patients that have active bleeding, you have that same concern. If you're increasing circulation, you're potentially increasing their risk of bleeding. So patients with any hemorrhagic disorders, you should be cautious of that. And kind of expanding this a little bit further, if you have a patient with a DVT history on one side of the body, you should be cautious in applying electrical stimulation to the other side, so right versus left, because they're seeing that you can have reflexive vasodilation on the opposite side. So in doing so, you may be increasing the risk for that patient. So don't think of this as just a contraindication in the region where you're applying the stim. Remember to think about the whole body and how our various systems are going to interact. It's a very low potential, I should say, of that reflexive vasodilation, but the risk is great and the consequences are high if it was to happen. Another area to consider, those of you that may be utilizing electrical stimulation over acupuncture points, be cautious that you truly understand what the reflexive properties are and other systems that are influenced, because you could be stimulating one area and have a reflexive reaction in a different area with circulation where you're placing potentially the patient at risk. So just be aware of that. The other one that we always memorize is not to perform electrical stimulation around the abdomen or the low back during pregnancy. And just to reiterate why, what happens is when we apply electrical stimulation in that area, we are going to have a release of endogenous opiates into the circulatory system. And those opiates tend to be very potent stimulators of myometrial contraction, placing that woman at a potential risk of miscarriage or even early labor. So we're really going to be cautious in avoiding that. Same thing if you're using acupuncture points in someone that's pregnant. Make sure that you truly understand what reflexive points you're utilizing, because you could be releasing those opiates into the circulatory system that could stimulate this unwanted uterine contraction. In some instances, TENS is actually utilized during labor to help manage the pain as an alternative to pain medication or other methods of pain management. And that is a completely different application. And at that point, the woman is already experiencing her contractions and the physician is supervising. So we don't have the same concern over this contraindication as if we were seeing the patient just in the clinic. Consider your patients with any implanted cardiac device, any implanted electronic equipment, a contraindication for the application of electrical stimulation. If you have something implanted that is already working electronically off of a battery and you influence anywhere in the body another electrical current, introducing that secondary current could cause malfunctioning of the device. So it's best to consider that any patient with any kind of electronic implanted device, you should not be utilizing electrical stimulation. And this list continues to expand as technology advances. So we're not only looking at our pacemakers for our patients, but we're looking at AICDs, automatic implanted cardiac defibrillators. Patients may have implanted TENS units, baclofen pumps, insulin pumps, bone stimulators. The list goes on of what patients could have implanted. Maybe they have a deep brain stimulator to manage their Parkinson's. So we need to really be aware and cautious of this. And it's something to take very seriously because, again, the consequence is high. There was an interesting case back in 2010 in California where there was a PT with over 20 years of experience, skilled clinician, who was treating a chronic back pain patient who would periodically come in as there were exacerbations of his pain. He would go through a course of therapy and then return again. Well, his patient happened to have a pacemaker implanted, and the therapist was utilizing electrical stimulation to treat the patient's back pain. It was very risky and uneventful for the patient until one of the times when the patient was discharged and they came back. In that time period, the patient had a defibrillator implanted. Well, upon their return to therapy, when electrical stimulation was utilized, it activated that AICD and led to a cardiac incident for the patient. Patient survived, but this therapist was brought before the board because, as we're saying, you have an electronic device, you're introducing a current. There should be no question there that that should not be done. So the board did actually find that that therapist was guilty of gross negligence, that their application of the electrical stimulation was an extreme departure from accepted standards of practice. So these are things that unfortunately do happen out there. So we want to avoid that in our practice. Thinking about patients who have areas of known malignancy, again, if your patient is near end of life and you are working with the physician using TENS or stimulation as a palliative treatment, that is a separate discussion that you're going to have with the patient, the physician, and you to decide the risk-benefit analysis there. We're speaking in general that patients who have malignancies, if you're applying electrical stimulation in the area over the malignancy, so let's say your patient has a history of melanoma. Some research studies have found that the application of electrical stimulation in the area where the tumors are located actually promotes DNA synthesis and cell replication, causing the cancer to grow. And then because of the circulatory changes, that angiogenesis and growth of new blood vessels can potentially provide the nutritional support for that tumor growth. So that's where we're saying that we want to again consider that over an area of known or suspected malignancy, we should not be applying electrical stimulation. when we look at our specific beneficial physiologic effects of electrical stimulation, this is what we want to accomplish with our current and the direction we should be heading in with our applications. If you think about current in a general sense, electricity is going to take the path of least resistance. It is going to travel through our high water contact tissues, our good conductors. So those would be our nerve, muscle, cell membrane. And I usually say, when I'm giving this lecture around Halloween time and all those B horror movies are out there, how do they kill the monster? They put the electrical wires in the puddle of water and electrocute them. Current takes the path of least resistance. Well, it does the same thing in our body, that the tissues that are going to be most responsive that we can affect change in are our nerve, muscle, cell membrane, and blood vessels. What's not as responsive are going to be our bone, tendon, cartilage, ligament, and fat. And it's important to remember that the tendons are not as responsive as the muscle. Tendons do not have the same vascularity as our muscles. They do not conduct the current as well. So when you're looking at applying your electrodes, I'll use my arm because it can be seen. If you're treating the wrist flexors for the patient, well, our muscle belly of our wrist flexors is up here, proximal medial. It becomes more tendinous about halfway to 2/3 of the way down. So when you're placing your electrodes, you really want to be cautious to palpate over the muscle belly and place your electrodes there, because if they're down here over the more tendinous area, you're not going to meet with as much success with your intervention, and you're not being as specific in your application. So bear that in mind. Always use our anatomy knowledge to enhance our treatments. Once the current is applied and it penetrates through the skin, what is going to happen, our sensory afferent fibers are located superficially, and then a little more deeply, we have our motor nerves. On the outside, our resting membrane potential, we are going to have a positive charge. And when a nerve depolarizes, that flips and it becomes to a negative charge, as we have that alteration in our sodium-potassium pump. That's normally what happens. When we apply electrical stimulation, we're doing it from the outside. So what happens is those large diameter nerves with a larger surface area on them, those are going to be more responsive to the electrical current. We're going to be able to depolarize those larger diameter nerves more readily, and that will happen first. And the ones that are more superficially closer to where the current is will respond initially. So this is why our patient is going to feel the tingle of the electrical stimulation first, because those beta sensory fibers are going to be depolarized, conducting that signal up to the brain for recognition of the current, because we are going to depolarize those particular nerves. what happens as we have depolarization and the impulse is being propagated down our nerve, we're going to reach a point where we're starting to stimulate our motor nerves. So we'll stimulate our larger diameter nerves and then progressively smaller diameter nerves to the point where we have depolarization of our motor nerves. Once that motor nerve conducts its signal, it crosses the neuromuscular junction and it reaches here, our muscle fiber. And then it's going to cause that muscle fiber to contract in order to elicit the motion. And it's important to remember that this nerve to muscle connection needs to be intact for NMES to work. So your patient, for example, who has Bell's palsy, if they have at least that, one muscle grade where you can palpate that twitch contraction, then you can use NMES that we're discussing today. Well, you wouldn't use it on the face, but theoretically, if you had the equipment to apply it appropriately on the face, you could. If you do not have an intact nerve to muscle connection, a palsy in any area, this is not the type of current that you are going to utilize. You would select a different type of current. As our motor units are going to be recruited, this is an important distinction to make, that normally when we contract, if I am going to perform sit to stand, well, when my quads contract, my body is first going to contract my smaller diameter, slow twitch muscle fibers, and those are going to be my more endurance fibers. That through Henneman's principle, it's called, that our body, based on size, is going to recruit the motor units that we need, the smaller ones first, progressing to the larger ones as we need more strength and power. It's going to first recruit our more atrophy resistant, our endurance type muscle fibers, and then as the task becomes more demanding, then we're going to recruit our type 2 power fibers. That's normal because we're trying to minimize fatigue. What happens with electrical stimulation is completely the opposite. Remember I said that when you apply the electrical stimulation current, that the body is going to respond. The tissues that have the larger diameter, larger diameter nerves with greater surface area are going to depolarize faster. Those happen to be related to our large diameter type 2 fibers, our fast twitch muscle fibers. Those are our power fibers. That's what you're going to recruit first with your electrical stimulation. So this is actually opposite normal recruitment. We recruit those power fibers first. And this is beneficial to us when we're rehabbing patients who present with disuse atrophy. Because when we have atrophy setting in, whether it's a muscle wasting pathology with age, post-surgical or post-immobilization, we're going to see that we tend to lose those fast twitch type 2 fibers first. Our atrophy is going to occur in those power fibers. So by using electrical stimulation on these patients, we have a better ability to help offset that atrophy, to make maybe quicker gains in regaining strength for those patients by using electrical stimulation. If we combine that electrical stimulated current contraction, we get those low threshold motor neurons, those strong type 2 power fibers to contract. Combine that with active movement while the current is on, the patient's actively contracting their type 1, the combination allows for better strengthening, and these physiologic effects are some of the reasons that you might choose to use e-stim on your patient who's presenting with that disuse atrophy. Another aspect to consider is that the way our skeletal muscles regenerate is going to be related to these specific cells called satellite cells. And satellite cells are, they're called myogenic stem cells. That means that if you look at each individual myofibril sitting on the outside of the membrane, just quiescent, meaning just waiting there silent, we have these satellite cells. When our body moves into a repair and a recovery process, those satellite cells activate and they fuse to help increase the diameter of that muscle fiber and stimulate its healing. So that's beneficial. That's what we want to happen. Well, what they're finding in electrical stimulation research is that electrical stimulation will actually invoke the action of those satellite cells. It will stimulate them to contract and to begin the healing process. That when they took mice who had hind limb unloading, so they took mice and in one limb they induced muscle atrophy through not allowing that limb to be utilized, and the other one they allowed movement of. And when they applied the electrical stimulation, they found that the limb that had the unloading, the disuse atrophy that was induced, when they applied the electrical stimulation, they saw better retention of these satellite cells, that after the stimulation was completed and then the mouse was allowed to reuse that limb again, that they had a better pool of these satellite cells to help stimulate the healing. So we find in the research, they're saying that with disuse atrophy, not only do we lose type 2 fibers, but our satellite cells undergo apoptosis. That means a death of them. That electrical stimulation can help retain those satellite cells so that we have a better chance of recovery and muscle growth and repair when we do move back in to active motion. And I find this physiology fascinating, and I hope you do too, in the respect that there's so much happening when we apply electrical stimulation that some clinicians may view it as a passive modality. If you are very conscientious in who, when, and why you choose to utilize it, you're eliciting all these very beneficial physiologic effects. And when we set our parameters, we'll talk about there's a specific value that you need in your parameters to reach these beneficial effects. Another aspect related to the functioning of our cells is the oxidative capacity of our muscle cells. This is very important for recovery. And what they found in healthy subjects, as well as I found some studies looking at patients who underwent spinal cord injury, that there tends to be a shift when we do not use our muscle fibers, that they move from an oxidative capacity to more of a glycolytic capacity. So they are not being as effective in their functioning. The research found that when they applied electrical stimulation, that it altered the oxidative enzymes and it actually allowed a greater oxidative capacity. So it is allowing better functioning of those type 1 muscle fibers. That we're going to increase our muscle fibers, that we're going to see them improve in their endurance capacity and work more effectively. This is also beneficial for your elderly population because, again, we tend to see that shift to be more of a glycolytic capacity. So this may be another way to tap in and enhance your exercise program in a specific isolated muscle group for those patients. Our ultimate goal to build strength and power is going to relate to increasing the cross-sectional area of that muscle, increase that muscle's ability to develop torque, and that relates to muscle fiber hypertrophy. And coming into this lecture, you may have thought of this as your first physiologic effect that's beneficial. We have all those other things happening also, and together what they're finding is that we can increase the cross-sectional area. They've seen it in mice. They've seen it increase the peak force. They actually had in one study where they had human volunteers that underwent electrical stimulation for isometric quad exercises 3 times a week for 8 weeks, and they used the parameters that we're going to discuss. And they completed a needle biopsy of the muscle before and after the intervention series. And what they found is actually a shift in the proteins that supported our change in fiber hypertrophy, that they saw significant endurance as well as strength gains, and they saw a 30% increase in maximum voluntary contraction. So there are many different benefits that we have here. There were also some interesting studies that were actually measuring through MRI the cross-sectional area of different muscle groups as over the course of time when electrical stimulation was utilized, and they saw positive benefits to improve the strength for those patients. We have many different ways now that we know of that we're improving the physiologic or altering the physiologic functioning of our muscles. And that'll lead us to our indications. Okay, well, because these effects are occurring, well, now clinically, how do I employ that to achieve my patient's goals? And that's what we're going to talk about in our second hour. So we are... are our indications for electrical stimulation. So when are we actually going to utilize this type of current? So referencing the effects of what we can accomplish, we're going to think about the situations where those effects may be beneficial in assisting our patients. And one example is muscle spasm. That if the patient has a muscle spasm, let's say of their lumbar paraspinals, where they have a protective spasm, that muscle contraction is creating a restriction in range of motion. They've gone into that pain spasm cycle where the protective spasm has lasted beyond the point of being protective. Now it's becoming pathologic, where they have pressure from the spasm compressing the blood vessels in the area. So we have less circulation coming in. So we have a little bit of tissue hypoxia setting in and tissue ischemia. The body is unable to have the waste products from the muscle contraction circulated out, so they become chemical irritants in the area, which can increase the pain. In doing so, the patient is not going to want to move that area, so we have shortening down of the tissues. When they actually do go to move, then it's going to exacerbate their pain more, and then they're stuck in this pain spasm cycle. E-stim may be one way that you could choose to break into this cycle by fatiguing out the muscle, forcing it to relax. Pain in general for our patients, when we are considering management of it in our clinical practice, generally speaking, we're going to try to determine what is the etiology of the pain and then tackle that. So if the patient has pain because of muscle spasm, if we break the spasm, we should alleviate the pain. If we can determine the initial cause, that's what we're going to treat. If you decide that you are at the point where you're just managing the pain directly in more of a palliative way, For example, a patient who has compression fractures of their spine, an elderly patient, and then they have difficulty breathing with chest expansion because of the compression fractures, that's placing them at greater risk of pneumonia or atelectasis. So you may decide that while they're healing, they just need some pain relief and the doctor is trying to limit pain medication. Maybe they need TENS or interferential. Those are other types of current that are beneficial for strictly pain management. NMES by itself is not going to treat pain directly, so that would be a separate conversation of how to directly manage pain. If we look at muscle weakness, that is an impairment where definitely the research is supporting utilizing electrical stimulation to increase strength of those type 2 muscle fibers through the satellite cell repair, the hypertrophy, the oxidative capacity, through all of those different pathways. And that's what I want you to think of as the currents on all of these different beneficial effects. I will tell you that in looking at the research, I did not come into this with a preconceived idea. I will tell you every one of my patients does not get electrical stimulation or a modality. It truly depends on what best fits their impairments and their recovery. There are many studies out there looking at patients with osteoarthritis of the knee and electrical stimulation to the quads. And some of them say there's no beneficial effect, others show great success. So there is a combination out there. What we're going to discuss in terms of the parameters are where there has been success seen in the outcomes with the electrical stimulation. We'll utilize those specific parameters. There are some studies looking at the use of electrical stimulation on patients in the intensive care unit, where could this be a viable way with someone who is in a coma or a patient who has cachexia, muscle wasting from cancer or chemo that has induced a neuropathy for that patient. Electrical stimulation is starting to be applied to those populations as a way to offset some of the atrophy that those patients are experiencing. And again, the research, it hasn't made its determination, so you may need to be specific to your patients with that, but it is showing in some of it that there might be promise or there might be an option there for these populations to use electrical stimulation. In addition to our traditional orthopedic patients where we know we can build muscle strength for them, or our patient who has difficulty with spinal cord injury, difficulty grasping, or has sustained a stroke and you're working on grasping objects for them. We know in that intact muscle that electrical stimulation is definitely beneficial in increasing strength. Edema is another aspect where we can use electrical stimulation to manage the edema. We're specifically today focusing on NMES, neuromuscular electrical stimulation. So the way that they support in the research the use of NMES for edema management is to apply it to the proximal muscle belly in order to facilitate venous return and the muscle pump. So if your patient has ankle edema from their inversion sprain, then you would apply the electrical stimulation to the gastrocnemius, a large vascular muscle, induce the contraction of the gastroc, so you're simulating that muscle pump that'll help relieve that distal edema. Because if the gastroc is contracting, it needs oxygen and nutrients brought in, and then it's going to increase its venous return also to remove the byproducts. In doing so, it's going to increase the circulation and venous return from that whole distal extremity. Marry that with positioning in an elevated position, and you can tackle that ankle edema. They've also seen benefits for patients who, let's say they have a crush injury of the hand or they have significant hand edema. Placing the electrodes, kind of sandwiching it on the palmar and dorsal aspect of the hand. You can utilize NMES with the hand intrinsic muscles, our interossei, our lumbricals, thenar, hypothenar muscles. So by stimulating those intrinsic muscles of the hand, you're eliciting that same muscle pump to help alleviate edema. Those are the two ways that I came across in the research where NMES was utilized. Specifically, if you're looking at edema in, let's say, the knee or larger joint areas or the shoulder, then you're looking at interferential current, which again is a separate conversation. You also want to be aware that the electrical stimulation for edema management, regardless of the type of current that you're utilizing, whenever a patient has edema of cardiac or renal origin, you should not be, through e-stim or any other modality, forcing that fluid back into the circulatory system. It's important to remember that our patients with cardiac disease or renal disease, the kidneys and the heart have determined that they can't handle the blood volume. So they have dumped, so to speak, some of that plasma volume out of the circulatory system into the interstitial spaces in the distal feet because they can't handle the volume. If you perform an intervention that's going to force reabsorption of that fluid, you are going to overload and stress the cardiac and renal system. So that's why a contraindication is any of that cardiac or renal edema. And often you know that it's cardiac or renal origin. If you see the bilateral edema, it should be a little bit of a red flag for you. When we're utilizing electrical stimulation in general, we're going to remember that it is important to be only a component of our interventions, that the research is still emerging, that a lot of what we do is anecdotal, and we are going to make sure that we're timing our intervention of the modality with our stretching and strengthening and manual therapy. In occupational therapy, you're particularly utilizing it to prepare the patient for performance of their functional task. And our associations feel so strongly about this that this is not, I'm going to go back in time to my early days of practice. This is not like the late 80s, early 90s where hum, some of you may remember, every patient had a hum treatment. That's what your O of the soap was, not mine, other people's that I saw. Hot pack ultrasound massage. So it was S, without complaint, O, hot pack ultrasound massage, A, tolerated whirl, plan, continue. Repeat, repeat, repeat. That is not therapy. And our associations are saying modalities alone are not therapy. The AOTA goes as far as saying that your physical agents have to specifically prepare the patient for a functional task or be used with a functional task, and you have to document that. The American Society of Hand Therapists reinforces this position. So everyone's in agreement that it is just a piece of what we are doing for our patients. But it can be a very beneficial piece for our trainers. They're saying the same thing, that it's a component of our techniques. Once you decide as a clinician that NMES, electrical stimulation, is something beneficial to utilize for your patient, we need to go into actually setting parameters to elicit all of these effects. And I don't know if you've ever heard of knobology, or I find it interesting. If this was a face-to-face class, this is when I might start to see the heads bow and the eyes gaze away. Knobologist is a tongue-in-cheek. That's for those individuals that you know which buttons to push on the machine, but you really may not know exactly what it's accomplishing. You go, yes, preset 1 is for pain management. Preset 2 is for muscle strengthening. Well, the reality is that there's a lot more that goes into that. That as long as you know everything that's under preset 1 and preset 2, that's fabulous. But we should, just like we are so specific in all of our other interventions and our manual interventions, we need that same level of critical thinking in our modalities. And every patient is different to elicit the various effects. So we're going to go through all the different parameters. And if you want to go program a preset 1 in your machine that is perfect for your population, so you know what it means, great. But I would encourage you to pull your units out when you go back in the clinic tomorrow, and pull the book out if you have it, or find it online, and look to see, because a lot of the manufacturers, they put in programs that they say are to manage specific impairments. Look and see what settings they have built in there, because they're not necessarily clinicians thinking of how we need to utilize it. Also think, if your machine is 5, 10, 20 years old, what preset 1 accomplished back then, I can tell you, is not the ideal parameters for now to manage that same impairment. So you need to go back and consider that. And so this is very, very important. I'll just share that in my teaching of my students, my rule is you can't use any presets, and for every button you push, you have to tell me what that parameter means, how would you increase that response, decrease that response, and have a critical reason for every single thing that you're doing with your modality, just like you do for all your other interventions. And that's what we're going to take time to look at for us now. And my hope is that many of you at the end will go, yes, I'm doing that, good. Or some of you, may get to tweak, but we don't have to see your gaze away as you're figuring that out. So the parameters that we are looking at are primarily frequency, amplitude, duty cycle, ramp, and time. Those are your key parameters. And some people were asking about pieces of equipment and buying different pieces of equipment. Those are your key parameters that you need to set to be effective with NMES, if you were looking just kind of bare bones at it. And to further complicate things, each manufacturer likes to use different terminology. It would be fabulous if it was consistent across all the manufacturers, but no, some of them have to be proprietary. So as we go through, I'll use the different terminology for you so that you know. I also bring this to your attention because when you go read other studies moving forward, you have to read past just the abstract. You need to get into the methods section and see what parameters did they utilize. Because if they're using settings that aren't what you're utilizing, or that fall outside of kind of what's already been established, that may influence the validity and the reliability of their results. That's another variable. So you do need to remember to look at that methods section if you're reading research studies to see what settings they're using. So our first one is frequency. Frequency is also referred to as pulse frequency, pulse rate. When you look at the different pieces of equipment, it may be labeled in an output of hertz, pulses per second, cycles per second. It'll be documented that way in the O section of your note also. Essentially what this parameter is looking at, the frequency is how often that waveform is coming out in a period of time. So in 1 second time frame, well, how many pulses or how many of this particular waveform do we have in that 1 second of time? It's an important parameter to note because it's going to influence the response of the axon to depolarization. So this is what's going to tell us essentially the type of contraction that we are going to achieve. Also remember that when you're documenting your intervention, you want to be very specific in your pulses per second and document your actual number. Because as I said, this is going to dictate the contraction. So on the left-hand side here, if you have, let's say, 4 pulses per second, versus on the right, we have 10 pulses squeezed into 1 second, that, imagine beneath the skin surface, as we shift between the positive and negative, and that is going to engage that nerve depolarization, that sodium-potassium pump, elicit all of these other effects that we spoke of, you're going to see that if we have more of that wave compressed into the 1 second, we have more shifts between the positive and negative and influence of the ions in the area, so you're going to have greater stimulation and greater contraction. Overall, the higher that you see your frequency, this is going to be the greater that you're going to see the contraction coming from the muscle. The research doesn't tell us a specific number. It would be great if they figured out if you're strengthening the quads, it should be 50. If you're strengthening the flexor digitorum superficialis, it should be 35. They haven't done that. Because there are differences in patients, think of your patients over the course of the day. The cross-sectional area of a large athletic patient's wrist extensor group may be the same cross-sectional area as your tiny pediatric patient with spastic cerebral palsy, or your elderly patient who had a hip fracture, ORIF, and has significant functional decline. So there's variability, and we need to take that into consideration based on the patient's goals, based on their tissue, and how they're going to respond to the current. But when you document your interventions, it is important that you put your set value there. Generally speaking, as we hit different thresholds for stimulation, different frequencies ranges, we'll see different types of muscle contraction. So if your frequency is set somewhere between 1 and 10 pulses per second, you're going to just get a very gentle twitch contraction, that you get at least 1 motor unit firing, so it's that very gentle, almost fibrillation of the muscle. This can stimulate a little bit of a lymphatic flow, a little bit of the circulatory changes to increase the muscle pump. Typically with NMES, we're not utilizing this particular frequency. You could make a case to use it for edema because you're getting that gentle twitch contraction, but generally speaking with NMES, we're not using that frequency of 1 to 10. Where our frequency should be with the electrical stimulation NMES are 35 to 50 pulses per second is going to give us a good, strong tetanic contraction. This means that we've depolarized enough to have stimulation and contraction of multiple muscle units, and they reach what we call summation. So they're contracting together in a cohesive manner to give us a good, strong contraction. And that good, strong contraction of 35 to 50 pulses per second is usually sufficient for our smaller muscle groups, they say. So that might be typical wrist extensors, anterior tibialis, wrist flexors. So our smaller muscle groups. If you were working in the hand, maybe your patient has carpal tunnel, so you have atrophy of that thenar eminence. So our small muscle groups, you're going to be somewhere between 35 to 50 pulses per second. This is also the frequency giving us that good, strong tetanic contraction that is sufficient to help fatigue out a muscle spasm for a patient. So we are going to utilize it in that respect. And what they found in the research is for patients in general, the higher range of the frequency that you could be in, the better your effect. So you'll want to kind of shift to the higher end of this range. Let's say your patient has a shoulder subluxation. So you're using the supraspinatus and the middle, the rhomboids to control that scapula. Those are smaller muscles, so maybe you're closer to your 50 pulses per second as compared to your quads or hamstrings or large muscle groups. There was one study that actually looked at the physiologic rate of firing of different nerves and muscle unit motor discharge rate, and they found that being at the higher end of the ranges is going to sync up better with the normal motor unit firing. So that's why we get a better effect at the higher ends of those ranges. And again, consider the size of your patient also. You can actually go beyond for strengthening that 50 pulses per second up to 80 pulses per second. And the newer research is saying that to be in that 50 to 80 range is most beneficial for strengthening, particularly of your larger muscles. So you're looking, maybe depending on the size of the patient, biceps, triceps, quads, hams, our larger muscle groups. The research is showing that over the 50 pulses per second is going to give you a stronger muscle contraction for better recruitment of those type 2 fibers and a better outcome. That's actually one of the aspects that the research across the boards really seems to be consistent upon, that you're going up with that frequency to be most effective in attenuating that atrophy and rebuilding the muscle. Our next setting that we're going to look at is our amplitude. Sorry. So amplitude is our next setting, also referred to as intensity. Some pieces of equipment may even label it as power. You'll see also. Frequency was our type of contraction. Amplitude is the intensity or the strength of that contraction. And when we look at setting our amplitude, that there's going to be a particular manner in which we recruit our different nerves. That current, as it's delivered to the tissues, is going to take that path of least resistance, and it's going to first stimulate our larger diameter fibers. That order of neuroexcitation, going from larger to smaller diameter, we're going to take a little step back here into physiology again, that our A beta sensory fibers, those are our larger diameter, faster conduction fibers that are located in our dermal layer. That is going to perceive our touch sensation. It's why if you're just sitting calmly, not paying attention, and someone could just come over and ever so slightly tap you on your arm or your shoulder and you jump significantly, it's because those A beta sensory fibers, they grab and conduct quick that signal to be perceived by the brain. Electrical stimulation, by taking the path of least resistance, is going to depolarize those sensory nerves first. That's why that patient is going to feel the tingle sensation of the electrical stimulation initially. So we get a greater depolarizing effect because those are very close to the stimulation application site and they are very large. As we continue to increase our amplitude or our intensity, then we're going to start to recruit our smaller diameter fibers. That's when our motor units, our motor nerves, A alphas, start becoming depolarized as we increase our amplitude. And as we continue to increase the amplitude and recruit more, you're going to see the fasciculation, then you're going to see the twitch, a little bit more of a contraction, and then you're going to get to the point of that tetanic contraction. So we're going to kind of go through stimulating all those different motor nerves, and if we continue to increase the amplitude beyond that, now it's going to reach a threshold where we stimulate those really small diameter unmyelinated pain fibers, those A delta and C fibers that perceive the noxious stimuli, and that will be perceived. It's important to understand this level because you need to achieve a certain type of contraction or a certain level of stimulation in order for your e-stim to be effective and achieve its goals and the physiologic effects. Have you ever had it where you place the current on the patient and you're increasing the amplitude and they feel the tingle, and then you keep increasing it and the next thing they feel is pain and they can't tolerate it and you never achieve a muscle contraction? Well, you went from stimulating your A beta sensory fibers to your C pain fibers. You missed having that current penetrate deeply enough to stimulate your motor units. And if you're strengthening, you're not achieving your effect because you're not depolarizing for the contraction. And the reason this is probably occurring is because the stimulation is becoming trapped in the superficial layers of the skin. It's meeting too much resistance to current flow, so it's just staying in the dermal layer. What that means is you should really be cleansing that skin before you apply the electrode, or you do not have good conduction medium to conduct the current down. That something is impeding the flow and creating resistance to it through the tissue layers that you need to correct for. So I would say mental note to self, if you go, oh, yes, that happens to me, you need to cleanse the skin to remove the dirt and oils so that the current can penetrate and have less resistance to get to those motor units. And you need to check your contact. Make sure you have a good conduction medium that's allowing the current to conduct. Because remember, the e-stim can't travel through the air. If it's getting caught up, if your electrodes aren't adhesive or you don't have enough gel, if it's a carbon electrode, then it's not going to conduct down. So be aware of that you have to achieve different levels of excitation. Just stopping at that sensory level of stimulation is typically not where we're going to end with our amplitude setting when we're using NMES. That sensory level would just mean the patient feels the tingle. It's as high as they can comfortably tolerate without pain, but you're still not seeing a muscle contraction. The time you may use it with NMES is, let's say, if you're performing muscle re-education with your patient. So they have the strength, maybe you're weaning off the electrical stimulation, or they just need a cue to recruit a specific muscle. Then you might just use a sensory level amplitude to let them know, oh, this is the muscle that should be contracting. So here's an example. Let's say your patient had an ACL repair. So you've been rehabbing them, you've developed good VMO strengthening, but when they go to do that step up, they're still not kicking in that VMO at the appropriate time for knee extension to be able to perform stance on that limb to step up onto the step. So that weight-bearing limb isn't kicking in its VMO. Maybe you have the electrical stimulation on there and you're timing it so that the current comes on and say, okay, now tighten up that muscle. So it gives them a little bit of a sensory cue. Or your patient where you're just trying to give them a little kinesthetic reminder, give them some proprioceptive feedback, you could stop at that sensory level. For the most part, you're going to be at a motor level when you're using NMES. Your amplitude needs to be at a level so that you're actually triggering a visible muscle contraction in order to achieve your benefits. If you're trying to fatigue out a muscle spasm, you actually need to see that visible contraction to know that you're going to fatigue it out. For edema to stimulate the muscle pump, that visible contraction lets us know that we're creating enough effort out of that muscle in order to stimulate the venous return. And then for muscle weakness, you want to keep increasing that amplitude so that we are actually achieving a contraction to achieve all those beneficial effects that we have discussed. There is not a specific number that you need to go to. I always tell my students, everyone's obsessed with that number, her amplitude. They're like, well, I got to 85 milliamps. Well, I got to 110 milliamps. It's almost like our total joint replacements with their range of motion competitions, except it doesn't mean anything when we're talking amplitude. As the current travels through and it meets the different tissue interfaces, so between skin and fascia and muscle and going deeper, it's going to meet different amounts of resistance. Even in the same person on different days, maybe they're more hydrated one day or dehydrated another, you're going to see a difference in the amplitude. That's why we don't set it to a specific number. We set it to a tissue response, so either motor or sensory level, because it'll take different amounts of current to achieve that. What the research also agrees on is that when we're performing electrical stimulation for strengthening, we have to get that amplitude to as high as they can comfortably tolerate. So we're marrying a high frequency over 50 pulses per second up to 80 with the highest tolerable amplitude, which means we're getting a good visible contraction, not painful, and you should really be striving to get at least 50% of their maximum voluntary contraction just from the E-stim, because that is going to stimulate all of the physiologic effects for those type 2 muscle fibers to combat the atrophy, and then you're going to combine it with their voluntary effort to get the type 1. So our amplitude has to be high enough to really be pulling in and recruiting those type 2 muscle fibers. And that's where we need the patient's verbal feedback also to make sure that we haven't gone past that, high motor contraction into noxious stimulation. So we do need to get some feedback from our patients, so they need to be cognitively intact enough to supply that. While our intervention is being performed, we are going to set a duty cycle. That means all the effects that we're achieving, do we need a break in them? while the current is on? Is it on the whole time that we're treating the patient, or do we have a period of time where there is a little bit of a downtime, a little break for muscle or tissue recovery to be occurring? Sometimes you'll see this called on the units on time and off time, pulse modulation, where you're seeing where you can set in seconds and on time or off time. And this is going to be determined again based on whether or not you feel there needs to be muscle recovery. A time during your overall session where the tissue is not receiving stimulation, where there's no contraction occurring. You have several ways that you can set this. You can set it to a continuous duty cycle, which means it is uninterrupted contraction. If your treatment time is 10 minutes, that means during the 10 minutes, the patient is going to be receiving, let's say, your 50 pulses per second. So we're getting a good tetanic contraction. You've increased it to a motor amplitude. So you're recruiting all of those muscle fibers in a good, strong contraction with a visible firing. And then it's going to continue that way the whole time that the treatment is being performed. We can imagine that if we have that good synchronized recruitment of the muscle fibers and they're holding that contraction, or they're obligated to hold that contraction through the stimulation, that eventually it's going to fatigue out. And this is going to be beneficial if you're managing muscle spasm for your patient. We want to see a fatigue occurring in the muscle so that we're breaking into that pain spasm cycle. When the muscle fatigues, it is going to allow increased circulation in the area to help combat the hypoxia. It's going to remove the chemical irritants, venous return, and then it should decrease the pain also for the patient. So now that that muscle itself is relaxed and not firing, it is going to allow the patient to achieve more range of motion. And just to clarify, when we talk about the pain spasm cycle, we're looking at muscle spasm, so the short word, where that protective reaction of our muscles after we have injury is to co-contract to stabilize the area. Pain spasm cycle is when that protective contraction to stabilize the area continues past the time it's necessary, and now we're creating negative effects in the tissues because of the circulatory changes and the pain. The patient doesn't want to move, so the muscle's shortening down, can fibrose a little bit. Joint capsule's not moving, so it tightens down, as well as the other periarticular structures. They go to move, it hurts, and they're in that cycle. So you can see by having a continuous contraction, requiring that muscle to contract so much that it fatigues out will break into that cycle, and then you can move in with your stretching and other interventions to start restoring length, elongate the joint capsule and periarticular structures to start restoring normal movement. Interrupted duty cycle is going to allow downtime and a rest. So when we think about our duty cycle, when it's interrupted, meaning it'll have an on time and an off time, we think about it in proportions or ratios. So either 1-to-1, equal work and rest, or 1-to-3. We have, 3 times the rests that we do as the work. We'll consider it as ratios, but when you're documenting, you have to document in seconds for specificity of your intervention so that you know if it worked, great, those are the seconds I want to continue with. If I just put 1-to-1 duty cycle, maybe one clinician thinks, well, it's 10 seconds on, 10 seconds off. Another clinician could say, well, a 1-to-1 duty cycle is 30 seconds on, 30 seconds off. That doesn't fit the standards that are out there. We need to be specific. So when you're documenting your duty cycle, it'll always be in seconds as your on-off time. A 1-to-1 ratio is indicated to simulate muscle pump when we are trying to manage edema. So you might have 10 seconds on, 10 seconds off, or a 5-second on, 5-second off. So that is going to simulate the muscle pump, allow for the venous return. If you picture those veins with the valves in them, with every muscle contraction, it is facilitating the venous return up to the next chamber. And from our arterial side, we have good, nice, clean circulation coming in with oxygen, nutrients, our cells that are necessary for repair. So we're equal work rest there to simulate that pump. If your patient with muscle spasm can't tolerate the continuous edema, it's just too uncomfortable for them, you can go with a 1-to-1 ratio. Just know that it's going to take a little bit longer for that muscle to fatigue out. So you want to be aware of that. When we look at strengthening, we're going to consider that the high intensity of the contractions from the electrical stimulation and the atypical way that we recruit with eStim, remember it's opposite our normal contraction. We're recruiting type 2 before type 1. They're going to fatigue a lot faster. So while we need the duty cycle to be long enough to induce the changes we need, we don't want to fatigue that muscle out too quickly. So it's going to need a longer rest time than it would with a normal physiologic contraction. So if you have your patient doing, let's say, quad sets, because it's easy for everyone to picture. So they do a quad set, they relax. They go into their next repetition, they relax. You know, hold 5 seconds, relax. Hold 5 seconds, relax. They have a very short break in between there, and you may be able to have them do 2-3 sets of 10. If your patient has significant muscle atrophy and you apply electrical stimulation while they're performing that quad set, well, yes, voluntarily during their 10-second on time, they're holding those type 1 fibers, and the eStim is contracting those type 2 power fibers. Well, they're going to need a greater relaxation time before they're ready for the next contraction. They're going to fatigue more quickly because we're having multiple motor unit activation, more than what's probably necessary for a quad set, but we have a different goal in mind if we've selected eStim. We're trying to stimulate, you know, different physiologic effects. So we need to build in a longer rest time so that we can get a nice full set out of that muscle group. So often what you're going to see is a 1-to-3 ratio. 10 seconds on, 30 seconds off seems to be pretty typical for strengthening to allow enough recovery time for the muscle to be ready to go for their next contraction. If the patient is extremely weak, you might increase that rest time to a 1-to-5. So 10 seconds on, 50 seconds off, in order to allow for more recovery before the next contraction is elicited. And you could almost use this in your weaning off of the electrical stimulation. If your patient, for example, has, let's say they have a flexor tendon repair. So they're healed, and you're working on the wrist flexors and the finger flexors in order to increase the strength. Let's say flexor tendon repair in the zone of the hand, and you're looking at the flexor digitorum profundus and superficialis. So we have our electrodes up here on the forearm. The patient's very fatigued, sensitive because they have significant atrophy while they were splinted for their healing. So now as you stretch and they're finally gaining some range, we have to teach those muscles to contract through the full range of motion, but they're very weak in doing so. So you may put the stim on and do 10 seconds on, 50 seconds off in between each contraction for the muscle to recover. And then over a couple of weeks, or maybe even less, they're building strength. And you say, you know what, a 50-second rest is too long. I'm going to increase the intensity of this exercise by now only giving a 30-second rest before they go into that next contraction. So we're progressing it that way for the patient with less rest time. ramp time is a feature that you should consider relative to your duty cycle. The ramp time is going to allow the amplitude to slowly reach its maximum and then stay there for the rest of your on time. For example, we have our patient and we are using, let's do biceps for the patient. Actually, I'm going to do biceps for my next one. Let's say the patient has a patellar fracture. So we are using electrical stimulation to the VMO and the rectus femoris on the leg, and we have them doing a TKE where they're kicking their leg out over a bolster. So when that current first comes on, it's going to slowly take a second or two to get up to the maximum amplitude we set, and then it'll stay at that amplitude for the rest of our on time, and then we can put a ramp down for it slowly to go back down to 0 amplitude. What happens is, we said amplitude is actually the process of recruiting the muscles during the on time. So by allowing it to slowly come up, we're slowly building our recruitment. We stay at our maximum to get our good, strong tetanic contraction, and then we slowly let off of that contraction. Doesn't that sound like normal muscle recruitment? If we're going to pick up an object, we're not going to come in quick and grab it. We are going to slowly build the contraction that we need, and then we're going to slowly release that, which may even be eccentric control. So you can use your ramp time to simulate the process of normal recruitment. You're giving more proprioceptive and sensory cues to the patient through the muscle contraction, and that's the re-education part. They've actually found that with electrical stimulation, another benefit is that it is tapping into the cortical centers through the sensory feedback to help with the motor process. So it's another benefit of those proprioceptive cues. So you can use the ramp to simulate the more normal recruitment. If you're really working on eccentric control of your patient, maybe you want a longer ramp down so that they learn to slowly let out that contraction. If you're working with a patient who has spasticity. So spasticity is a neurologic state where normally we have our monosynaptic reflex arc, right? We have our sensory afferent fiber goes up to our spinal cord, it synapses, and then it comes back down with our motor efferent that elicits our reflex. So our quick little reflex arc. Normally, our muscles as we move, the GTO is going to sense the length-tension relationship, and we may stimulate that reflex arc, But our higher cortical centers say, you know what, no, you don't need to be contracting that muscle now, and it shuts it down. When we have a neurological insult where from the brain down, we're not inhibiting that monosynaptic reflex arc, it's allowed to just continually fire. So our patients with spastic cerebral palsy, individuals following head injury, stroke, multiple sclerosis, different neurological insults where that reflex arc is firing. I think it's easiest to see in the spinal cord, where patient has an intact reflex arc going to the spine at L5, but their spinal cord injury is at T12. So the signals are not conducting up to the brain. So the brain can't get that message down to tell that L5 reflex arc to the leg to stop firing. It can't shut it off. So it's going to continually fire, and that's where spasticity or high tone is coming from, in a simple sense. We can use our ramp time on electrical stimulation to help combat that, to allow the patient better success with movement. So if my patient has spasticity of their biceps, so I have bicep spasticity, high tone. So whenever I try to straighten my arm out, my triceps aren't strong enough to overcome that reflex arc that keeps firing that's giving me high tone. What you can do is apply electrical stimulation to the triceps and set a really long on time, a really long ramp up with it. So as the stimulation is going into my triceps, the message is going to that tricep muscle to contract. Through reciprocal inhibition, our body cannot be contracting our bicep and tricep at the same time. So as that ramp is building up on the tricep, slowly recruiting it, it's inhibiting that bicep so that it can relax and give, and now the patient may be able to meet with more success when they go to contract that tricep. So it's a nice way in our neurologic patients that we can use e-stim to inhibit a spastic muscle and facilitate the antagonist to meet with greater success with movement. So it can work well there. They're showing some success, particularly in kids for grasp that have, let's say, spastic cerebral palsy, because it helps alter the muscle tension to let them meet with greater success for their movement. Your overall treatment time for your session is going to depend on what your goal is that you're trying to accomplish. Oftentimes, if you are managing edema with the electrical stimulation, you're going to be combining it with cold if it's post-exercise microtrauma or an acute edema, or you may be combining it with heat if it's more of a subacute or chronic edema that's stuck out in the interstitial spaces. So your treatment time may be, more like 10 minutes. If you're just using the e-stim alone for that muscle pump, you're going to maybe be on the higher end of that range. Whether or not you really want to spend 30 minutes with your e-stim, you have to consider. So oftentimes we're going to be really specific and at the lower end of the range. For muscle spasm, same thing, depending on the level of spasm. Somewhere between 10 and 30 minutes is allowable. Whether it's the best use of your treatment time, you have to decide. And that's where, if you're combining modalities, you're always going to defer to the treatment time of the modality that would cause harm if it's left on for too long. So consider that in your timing. When we're using the electrical stimulation for strengthening, we are going to consider how many repetitions we want the patient to perform. As we mentioned, because we're not just strengthening the type 1 fibers, that we're not going to be doing as many repetitions as we would be if it is the other portion of our exercise program that's just straight active exercise. So somewhere between 10 and 20 minutes based on how many contractions you want to achieve. And the way you're going to decide this is be considerate of your duty cycle. So for example, if your duty cycle is 10 seconds on, 30 seconds off, it's going to take you 40 seconds to do 1 repetition. So if you're treating the patient for 10 minutes, you're going to get about 15 reps in. If you're treating them for 20 minutes, you're going to get 30 reps in. That may be a little bit too much to maintain the quality of the contraction. Okay? So you're going to bear that in mind, how many repetitions you want for your patient. The last thing I want to say on treatment time is going to think about, as I mentioned, muscle re-education, that you can utilize your electrical stimulation to re-educate as that sensory cue, and also to stimulate some of those new synaptic pathways in the brain in our neurological patients through the sensory stimulation. And that if you're using the e-stim for a functional task, you're going to time the e-stim with the execution of that task. We are going to pick up for our final hour now on electrode placement and other considerations for physically applying the electrical stimulation at this point in time. When we're applying the electrical stimulation, you have decided why you want to do it. You've decided the parameters you need to execute that. Now we need to look at actually how do we set this up and where do we apply our electrical stimulation to be most beneficial. Typically with electrical stimulation and MES, we're using a bipolar placement. That means the lead wire coming out of the unit bifurcates, so our 2 electrodes are going to shift between positive and negative polarities for the patient. So this means the red and the black ends of the lead wire really do not have any impact because the polarity is constantly changing, hence the name alternating current. So some machines will be 2 black, some will be 2 red, some will be 1 of each. It's wonderful that the manufacturers do that to us. The key is that because the same amount of current is coming out of both electrodes, their diameter of the pads or the size and shape of the pads needs to be identical because you want to have the same current density coming out of both electrodes. So we're going to have equal pads. There are so many different types of electrodes that are available. Many of you may be used to the self-adhesive electrodes like the bottom left here. And what I want to remind you with those is that it does have the pigtail sticking out of it. So that is going to conduct the current down into the electrode, and then it's going to disperse it along the conduction medium. The adhesive of the electrode is the conduction medium, so it has to remain sticky, so to speak. Others of you may be used to utilizing on the right-hand side here the carbon fiber electrodes. If you've been practicing for a while like me, they may have started out as a metal plate that you had to put 2x2s saline soaked on and strap around to your patient. But if you use the carbon fiber electrodes, don't be afraid of them. They come in different sizes. You have to add your own conduction medium. So ultrasound gel or the water-soaked sponges that do have to be cleaned for hygiene purposes, and then you will either tape or ace around or with a strap to the patient's skin. A note on the carbon fiber electrodes, they do not live indefinitely. When you look at them, if they're starting to become dull, versus more of a shiny on the conductive side, that'll let you know that they're reaching the end of their life and it is going to impact the conductivity of them. So it might be time to get rid of them. It's important to remember that we have to have a conduction medium because the current will not travel through the air. So we need to be aware that whatever type of electrodes we're utilizing, that we have a good conduction medium for that. Sometimes I also like to use the carbon fiber if you're on an area where you're having difficulty getting the exact muscle. So let's say you're working and you're trying to distinguish anterior tibialis from peroneals. You know, you want dorsiflexion versus eversion. or you're trying to do extensor carpi ulnaris versus extensor carpi radialis, where they're close, and you're using smaller pads. If you use the carbon fiber, once you have contact, you can slide the pad a little bit to adjust your placement and then affix it. So that might be one reason you would pick one over the other. And then cost obviously does make a difference on these. If we look at the electrode packets, those of you that utilize the disposable ones, have you ever actually read what it says? And for this course, I did. When you read it, it tells you you are supposed to cleanse the patient's skin before you apply the electrode. It's very important that we remove any dirt or oil from the skin. You can use a little alcohol prep pad and then allow it to air dry the skin, because we are going to decrease anything that might impede the flow of the current to receive our amplitude that we need. So we're going to cleanse the dirt and oil away. If you are remembering instances or you have a situation where the patient is going from sensory to noxious level stimulation, my advice would be shut down, take it off, cleanse the skin, and reapply. That might be an indication that the current is not penetrating deeper through the epidermis. So we need that good conductivity for our patient. If we look at the actual areas where we want to place the electrodes, you're going to consider the impairment that you're managing. We need to remember our anatomy in order to have the most beneficial placement. Think about the layers of your tissues. Generally speaking, electrodes that are placed closer together are going to penetrate more superficially. If we have one electrode and then another electrode here, that current, pick another pen here, is only going to have to travel like this to conduct from one area to the next. If those pads were to be further apart, the current would have to penetrate more deeply in order to close that circuit. So we'll get deeper penetration. It's important to remember that as you think about the different layers of your tissue, that if you're trying to achieve contraction of a deeper muscle, we need to place those electrodes further apart. At minimum, the electrodes always need to be at least one pad width apart, and then they can be further than that. If we consider the area, if our patient has a shoulder that's subluxing, so we're trying to up here stimulate the supraspinatus muscle, we're going to remember that that supraspinatus sits deep to the upper trapezius, so those pads are going to need to be a little further apart. If we are trying to stimulate the quads, it's a large, deep muscle group, that vastus intermedius is sitting, it has thickness to it. It sits deeper below the rectus. And we're going to want those pads further apart so the current travels more deeply, covering the entire quads. Think about another example in your forearm. If you're working on grasp with the patient and you want that flexor digitorum profundus because you're doing distal interphalangeal flexion versus your flexor digitorum superficialis that does interphalangeal, or maybe you're just trying to stimulate wrist flexion for that spinal cord injured patient. So you're trying to get the flexor carpi ulnaris and radialis. Well, all those muscles sit in different layers. So if you're not achieving the response that you want, you have your electrodes on, your frequency is set, you're increasing your amplitude, but when you get to that 50% max voluntary contraction, you're not getting finger flexion, you're getting wrist flexion. Well, maybe you're only stimulating the superficial layer of tissues, your pads need to be further apart, or vice versa. You're going to look at the actual placement, but also think about that distance impacts your depth of penetration. When we are treating for muscle spasm, we are going to palpate where the spasm is located and then place the electrodes on the top and the bottom of that muscle spasm, kind of surrounding it. And we're going to go parallel to the muscle fibers. This means that if we are looking at the upper trapezius and the patient has spasm, we're placing one electrode here up in the cervical region, and then the other one more distally closer to the acromion, and this current is going to travel in this direction parallel to the muscle fibers. So it's going to stimulate the nerves in between that area, recruit the muscle fibers in that region, and that's in the direction of the muscle fiber contraction to maximize our benefits. So for spasm, you'll surround where that spasm is located for the patient. Another option, if you are utilizing electrical stimulation to manage spasm, is to place it over the trigger points. You can palpate where the trigger points are located. Those of you who are orthopedic clinicians, you know that that rhomboid trigger point is a culprit for many of our shoulder patients because that's scapular instability. And then upper trapezius is another common one if someone's substituting and protecting with their shoulder to compensate for upper extremity impingement. You might decide that you're going to put your electrodes just over those two trigger points. The trigger point, just to refresh for everyone, in a very simplistic explanation, it is a thin myofibril level that we're looking at where we have a sustained contraction at that level. It is going to create a spasm and irritation in that area. We have little chemical irritants that build up. So the nerves and blood vessels in that area are impacted, and it creates a little isolated area of pain when palpated for the patient. And that pain radiates in a specific pattern that's reproducible. And what we need to do is fatigue out that tiny area of the irritation, restore circulation in the area to relieve that trigger point. Because it is a neurovascular hyperactive area, electrical stimulation, it takes less amplitude to stimulate at that point. So you might have a better reaction and relief of kind of your protective spasm in the whole area, as well as the trigger point, to place your electrodes right over the trigger point. I will caution you, however, that it will be uncomfortable for the patient. But we know that if you're doing trigger point work anyway, their pain is going to increase in an effort to achieve greater relief. So make sure your patient education is strong there so that they come back again and they understand what's going on. Continuing to talk about electrical stimulation for spasm, if you are treating bilaterally for your patient, you need to consider that when the patient has spasms on, let's say, we're looking at the image on the right here, on their left paraspinals, you palpate where the spasm is located. So we are in this region. The current's going to travel between here to fatigue out those spasms. Well, the two electrodes of that channel are surrounding that spasm. So this may be your channel 1. And the electrode, the current's going to travel through the muscles, the erectors on that area to fatigue out their spasm. On the other side of the body, maybe you palpate a slightly different area of spasm. So you place your electrodes surrounding that area of spasm and the current can travel. This is going to be channel 2 for the patient. We need to keep the two channels on opposite sides of the body with the two electrodes conducting just on that side of the body, because remember, you're trying to stimulate the muscles in between that whole area and the nerves. So it makes sense that they do not cross because we're using NMES here. Also think about that there might be different tissue resistance to the current flow. There might be different tolerance. You might be stimulating different layers or depth of the muscle, which takes a different amount of amplitude. So by setting up the two separate channels, you're also allowing your amplitude to be set independently to be appropriate for each side of the body. So it's important if you're treating bilaterally to use two separate channels. What you're not going to do when you're utilizing NMES is on the left-hand side here, you're not going to cross the spine. Because think about what we're trying to accomplish. If we place one electrode on the left semispinalis capitis, splenius capitis, levator, all of those cervical muscles, extensors, and the other one on the right, how is this current trying to travel? What the current's going to do is try to travel this way. That's not the direction those muscle fibers run in. Both left and right side of the body, they are not going to need the same amplitude for treatment. So this is not going to be an effective intervention. That's why with NMES, for these impairments that we're discussing, we're not crossing the spine. When we are looking at managing edema for our patients, I mentioned that we're going to utilize the muscle pump to be most effective. If we are looking at using the gastrocnemius, we'll place our electrodes on the muscle. It is going to be combined with elevation to stimulate that muscle pump and gravity to assist with venous return. If you want to apply your stimulation current directly to where the edema is on the ankle, then you're looking at utilizing interferential current. And some of the research supports that interferential current may be more beneficial for management of edema because you can treat right where the edema is located, and that waveform is different, it penetrates deeper, elicits slightly different effects to be more beneficial around joints for edema. NMES, if it's the only unit that you have at your facility, you're going to really only be able to treat ankle edema utilizing the gastroc muscle belly, and there is research to support that. And then, as I mentioned, the hand. Other than that, the research doesn't have much out there about using NMES for edema in other regions like the knee, the shoulder, etc. Because you don't have a proximal muscle belly to use in those cases. Our electrode placement for muscle strengthening or re-education is going to be related to the specific muscle that we are attempting to stimulate. We are looking at applying it directly over the muscle belly. There's debate in the literature as to where is the exact best place to put that electrode. It would be nice if there was, something very prescriptive to tell us it should be 1 inch here or 2 inches lateral to that, but that doesn't exist. What they do agree in the literature is that the closer you can get to the motor point, the less amplitude you're going to need. The motor point is where the nerve is entering the muscle to initiate that propagation of the stimulation down the muscle fiber itself for our actual contraction. So the closer you are to that neuromuscular junction, the less stimulation you should need because it's more responsive. You'll get a better effect. However, it's really impossible to memorize where the motor point is in every patient. Some research says the motor point shifts as there's atrophy. It may not be in the same place anymore, and every patient's a little bit different. So shoot for a motor point, but at minimum, what you're going to have your patient do is, I'll use wrist here, is you're going to resist an isometric contraction, palpate that muscle belly that you're looking for, and then place your electrodes proximal and distal on that specific muscle belly. Because then it's going to allow you to conduct the current between that muscle belly to elicit your contraction. This is where you're going to remember, as we discussed, that it's the muscle itself that's more receptive, not the tendons as much. So particularly in the forearm or the distal lower extremity, you're going to be cautious to make sure you're over a muscle belly. So you're going to want to palpate that and then place your electrodes parallel to the muscle fiber for the patient. If you are able to memorize or know where the different motor points are located, then what you can do is go over a motor point. A common example of this is the lower extremity. If we look at our patient with a total knee replacement or ACL, MCL injuries, patellar tracking disorder, where we have weakness of that VMO, one electrode typically will go over that vastus medialis, and then often proximal here on the rectus femoris is the other electrode placement. You can use a larger electrode. Choose a size that's going to cover more of the area based on the size of your patient's extremity. So a larger electrode will cover more of the area and deliver more current. And then because these electrodes are very far apart, the current's going to travel very deep to stimulate more of the whole quadriceps muscle in that area. This is where we said distance makes a difference, as well as the size of your electrode being large enough. And sometimes that'll allow you to stimulate multiple muscle bellies in the same area. If that's not sufficient, what you can do is add a second channel and then put one over the lateralis, one over the medialis, and use all four on the same muscle group in order to achieve a better contraction. When we consider the size of the electrode, I mentioned that you have to look at the placement over the actual muscle belly, and this is where picturing beneath the skin is important and makes a difference. That if the electrode is too small, it is going to concentrate the current too much, and if it is a large muscle group, you may not be able to reach that motor threshold to see the visible contraction. You also want to think about, if we're looking here at the hamstrings, that it does become tendinous down by the knee. And our hamstrings are two sets of muscles. So we have medially, we're having our semimembranosus and semitendinosus, and then laterally we have that biceps femoris. There might be a little gap in between there. So if you just put two tiny electrodes, you may not be effectively stimulating enough of the muscle bellies to achieve that motor level contraction. Remember, we want to get to a 50% maximum voluntary contraction. Using the larger electrode is going to allow you to span more of the muscle, be more likely to hit over a motor point, and more effectively stimulate your contraction. And then the current will travel in between, catching all points and more of the muscle fibers of that hamstring. If you want to learn more about motor points, there's actually ways that you can map out the motor point for your patient. There are some resources out there where they have looked at where they feel the motor points are located. So one of these examples is included in the PowerPoint for you if you want to try and find where you have the best opportunity of eliciting that contraction. And sometimes that's beneficial, particularly in our neurological patients, where they may be uncomfortable, where we want to be very specific in our interventions so that we do not utilize their muscle endurance up for an intervention that's not very effective. So you might want to consider looking at your the motor point resources if you're interested in that. Patient positioning that you're going to consider is based on the intervention that you're performing. Obviously, elevate for edema. For muscle spasm, you want the patient in a position where they're relaxed. If you are performing electrical stimulation for upper trapezius muscle spasms, don't have that patient sitting, because that upper trapezius is functioning as an extensor and a lateral flexor of the neck to hold the head against gravity. But your E-stim, if you set it to fatigue out the muscle spasm, is telling that muscle to shut off. You're not maximizing your intervention. That patient needs to be maybe prone if they can tolerate it, or Fowler's with the head supported, so that upper trapezius can actually shut off. And maybe have them positioned so as that shoulder relaxes, it drops down a little bit. Origin and insertion are further away, so you're getting a little bit of a progressive range of motion as there's muscle relaxation. Think about this in your various positioning for your patient. When we consider strengthening, we know that the patient needs to be actively contracting along with the electrical stimulation. So you're going to consider your manual muscle test grade. The electrical stimulation, in addition to all of the physiologic benefits, is almost an active assist with the activity. So you're going to consider your muscle grade, whether you want them against gravity or gravity minimized to complete the motion. When we look at the quality of the motion that the patient is performing, we need to make sure that it's maintained through the entire treatment time. Just like you would with your therapeutic exercise, when the patient gets to what, rep 8, 9, 10, they should be working pretty hard, but they're able to complete the motion with the same quality of movement without substitutions, going through their full available range of motion, slowly letting up if it's an eccentric contraction, slowly recruiting to develop their power. All those same TheraX principles we're looking for when we look at quality of movement for the e-stim assisted repetition. So if you see that the patient's range of motion is progressively decreasing over your repetitions, that tells you that they are fatiguing out. So either increase your rest time of your duty cycle, decrease your overall treatment time because that gives you less reps, or maybe change the position. Maybe the resistance of gravity is just too much for the patient to continue with the exercise. So bear those same considerations in mind when you're doing electrical stimulation on your patient for strengthening. We should be monitoring the quality of that motion just like we would as if it was a regular exercise intervention. And then consider the type of contraction. Do you want an isotonic contraction where they're moving through the range of motion, or do you want an isometric contraction? For a lot of muscles, it depends on what is most specific to recruit that particular muscle. Or are we trying to carry over to a functional task because we're also giving that sensory proprioceptive input? Maybe you'll pick a different activity. Bear that in mind as you're using the electrical stimulation for strengthening. When we're doing that muscle re-education, we're considering that we are able to maybe decrease the amplitude over time. If this patient, for example, we're doing electrical stimulation to the anterior tibialis here because they have decreased swing through during initial and mid swing. Their toes are dropping down into plantar flexion and they're dragging because the anterior tib is not contracting. Well, this might be a patient where we're using the electrical stimulation actually during the task. So we're going to alter our position for that patient. Maybe we want them in standing because we want them to pull that dorsiflexion in as they're doing the hip flexion. Or maybe it's earlier in their rehab and they're just starting to get return and do active dorsiflexion. So I have them supine or side lying just to do that dorsiflexion independently to build its strength. And then later we'll incorporate that back into the entire functional task of our gait. The same would be true for your patient if you're working on the wrist or the fingers for grip. Do you want to use the e-stim by itself to isolate and achieve the benefits we discussed, or are you trying to tie it into a full functional activity? And I've said it more than enough. If the electrical stimulation could just be applied and reap its benefit and give me ripped abs and awesome biceps, I would not look the way that I do. But it doesn't work that way. We need to combine volitional movement along with the electrical stimulation to get that carryover for function. Some safety considerations as you're doing all this, just to refresh on the little pieces of. We are going to have our equipment calibrated annually to make sure it's functioning properly. If you are applying the electrical stimulation along with another modality for the spasm, for example, using a hot pack or a cold pack, you're going to want to position that hot pack or cold pack over the treatment area where the electrodes are first, then have the patient get in their position, all before you increase your amplitude. Any kind of pressure or force exerted over those electrodes will increase the conductivity and could injure the patient if the amplitude is too high, and then you strap that hot pack on. During the intervention, you should not need to increase the amplitude with NMES for the reasons that we're discussing. We're trying to elicit muscle contraction. That's not going to accommodate. It's going to reach its threshold and then continue to contract. So you shouldn't need to increase your amplitude during the intervention. If for some reason you did, please make sure you do that while the duty cycle is on. Know the lights on your unit. Do not increase the amplitude when the duty cycle is off. The electrodes that you are utilizing, you want to watch. Some of them, the adhesive of the electrode is right around the electrode itself, and then the pin from the lead wire enters that. So if the adhesive gets on the electrode lead wire, and go look at yours tomorrow, if they're starting to look a little green or they have something stuck on them, that is going to not only decrease the connection, but it alters the conductivity and the quality of the electrode because, of the lead wire, because it can corrode the lead wire and potentially damage the unit. So check those lead wires for the quality of them. You might need to clean that off. Also, if you're having the patient perform and move during the intervention for strengthening, you have to make sure that the weight of the lead wire, the way that this wire is laying against the electrode, is not going to pull that electrode off during the treatment. So watch how you have the tails lying so that you do not alter the contact. And these sound like such simple little things, but it's always good to refresh on to maximize our safety for our patients. This is always a good discussion. Those self-adhesive electrodes, which is what we call them, they're also called disposable electrodes. They have to remain adhesive. So when you pull them away from the plastic that they're on, they should still be sticky. You want to make sure that it is adhering because that is your conduction medium. If they are not adhering to that plastic, they are not going to adhere to your patient. If you just look at them and you see the skin and the oils and the dirt, that's not going to adhere. You essentially don't have conduction medium left. You're placing your patient at risk for burn, for that current to be trapped in the superficial layers. You don't want them to dry out. For hygiene purposes, they should be assigned to one patient. So what many clinics do is on the bag, they, put patient's name, date, seal the bag so they don't dry out, and keep them someplace stored for that patient. As I mentioned, they are disposable. That means when they reach their life, you throw them out. Again, good time that I can't see faces, right? Because some of you are going, moving forward. We throw them out. We do not reconstitute them with ultrasound gel. The idea is the adhesive is your conduction medium. So if it is not sticky, it's not going to conduct. Risk of burn. Beyond that, your intervention won't be effective because you're probably not going to get beyond sensory level stimulation. And if you do, it'll probably just be noxious. It's not going to conduct well. So get rid of them if they've lived their life. Don't pull on the tails of the electrodes because this tail is the lead wire that's going into the unit, into the electrode from the unit to conduct the current and disperse it along the electrode in your conduction medium. If you loosen that and pull the tail, you're disrupting its ability to do its job. Also, make sure you have a full connection. On the left here, we have a great connection. On the right, see this space? That's an exposed pin on your lead wire. The current is coming through that during the on time. Depending on where that is resting, that's an area that could be a burn, and you're not conducting your full current through that electrode, so it's going to alter the impact of your intervention. So make sure everything is connected well. All these little pieces do make a difference in your intervention, so it's nice to review them and be aware of it. In addition to looking at the big pieces to make sure your parameters are where they need to be for your desired effects. And my hope is today that we covered a lot of different aspects so that you have a nice visual of what's really happening with your eStim intervention so that you can make the best decisions as to when to use it or not use it for your patients. Eventually, modalities do need to be DC'd for the patient, except if you're sending them home with a FES unit that you've worked with a physician on. But other than that, the goal is that eStim is a tool to help improve and achieve your outcomes, which may or may not be right for everyone. And today we gave you some different ideas of how to apply that. TENS for muscle re-education. Okay. Alberto, you're asking about TENS for muscle re-education. TENS works differently. It is an alternating current, but when you open up the little unit to look at it, you do not have all these parameter settings. The biggest difference is you can't set a duty cycle. So you can't use it for strengthening because you have no rest recovery time. Person, bariatric patient, adipose tissue. That is definitely a consideration, Remo. You definitely want to look at skin integrity, and then you have to consider when you're palpating, you have to see if you can discern where the muscle is. Otherwise, you may just be trying to stimulate through adipose tissue that really isn't going to conduct very well. You may not be over the muscle belly. So definitely have to be cautious on that and try to be as precise as possible. I don't have any specific research on it though, sorry. So Lisa, with scissoring, the first question I would have is, are they scissoring because of high tone of the adductors? Or are they scissoring because of ataxia and poor foot placement? So you want to determine that. And eStim in that case may not be the best choice, developmental sequence and facilitation inhibition. So if it's high tone, theoretically, to utilize electrical stimulation, you would use it to the glute medius and minimus to reciprocally inhibit the adductor longus magnus gracilis. If you've tried other things, traditional tone management techniques that have not been beneficial, then this might be something to use. But if you think about the region you need to be in, it may or may not be appropriate to put e-stim in that area for the patient. So I can't give a specific answer on that, but I can say personally there are probably more inhibitory techniques I would try before I'd go to e-stim, because you need more diffuse inhibition of the entire extremity as opposed to just the adductors in one small area. Can we place the electrodes in the area where the shingles exacerbation is occurring? I would be very cautious with that and probably avoid it because the skin is not intact. So you are applying electrical stimulation with adhesive or conduction medium to skin that is not intact, which would not be appropriate, from risk of infection to conduction. If you are looking at stimulation in terms of the pain management, then that would probably be a different type of TENS. Okay. So if you have patients who present with disuse atrophy, the research is saying that all of these different physiologic effects can be beneficial. Muscular dystrophy would be included too. I've seen some research on that. In all those instances, there's different types of atrophy of the cells that you can be tapping into these different physiologic effects in order to make some beneficial gains. So think of those pathologies like you are, where they have loss of those type 2 power fibers, that the e-stim is tackling that, and then you combine that with voluntary movement at the same time to recruit the type 1, and together you're making these beneficial gains for the patient. Brittany, the research is saying that you should consider any electronic device implanted anywhere in the body as a contraindication for electrical stimulation. Because again, current takes the path of least resistance, and if you already have an electronic device in there, you really can't predict how it's going to respond. So if you have another way to manage that patient, it would be the safer choice to avoid the electrical stimulation. Lisa, so related to pregnancy, what the research indicates is that particularly in the abdominal back area, thoracic cavity, that you have, with muscle contraction, you have a release of endogenous opiates, and then those are going to circulate in the blood and can lead to myometrial contraction, that they've seen a connection there. So again, you really need to be cautious for your patients who are pregnant. Robin, I didn't see anything specific related to whether electrical stimulation would spread the virus. It follows the dermatomes during the exacerbation. So I guess it would be a valid question to ask if it could influence it. But honestly, I'm not sure. I haven't specifically looked at the research related to that. My preference with modalities is if there's a question mark, I treat it as a contraindication. That's just me personally. And Rosalind, that's similar also. When we look at patients who have cognitive impairment, electrical stimulation, they need to give us some feedback as to how they're tolerating that current. So if they are cognitively impaired and are unable to give us that feedback, we'll talk about when we're increasing amplitude, like, oh, I feel pain, not tingling, or muscle contraction. That could be indicative that the current is becoming trapped in the superficial dermal layer, creating a burn. If that patient can't give me feedback, then that would potentially place them at risk. And again, treat that as a contraindication. Also, if they're unable to participate in the intervention, if you're looking at strengthening where you need to combine actively contracting type 1 fibers with e-stim contracting type 2 fibers, if they can't follow your verbal cues to participate in that, then you're not achieving the goal of your intervention. So again, you have to take that into consideration. John, related to equipment, there is so much out there. What I would say is after today, you should have a good sense of what parameter settings you need for your population, and then look for a piece of equipment that will give you that. If you're looking to be most economical, you may not need one that delivers 10 types of electrical stimulation if you feel just NMES is going to meet the needs of your clients. So I would look for know what you need going in to service your patients, and then not get sucked in by all the bells and whistles you may not need. So Deborah asking what other populations may not be appropriate for e-stim. It would be those that you would consider where the intensity of the exercise may cause an exacerbation of their symptoms. So you would be cautious of that if the force of the contraction is too much for their pathology. So the questions coming up again about pacemakers and electrical stimulation. So looking at that, any implanted electronic device should be a contraindication. Historically, it's always been pacemaker, but moving forward, you should expand that definition to consider any electronic implantable device, because you're introducing a secondary electronic current that can interfere with the functioning of that device. So the question came up with some other diagnoses and using the electrical stimulation. Myasthenia gravis, I didn't see specifically in the research. I wasn't looking for it either, so it doesn't mean it's not out there. So you would just have to consider if it fits with that diagnosis, which, given the pathology, we would expect to see some disuse atrophy. That physiologically, it makes sense that the electrical stimulation could be beneficial for that patient. So just we need to remember that we have the benefit while we're using the stimulation, and then if we can retain the recovery afterwards. If someone has a progressively degenerating neurological condition, you might be using the e-stim to keep up, or you might be looking at using more of a functional electrical stimulation to make up for their functional deficit. So maybe the patient has a stimulator for wrist extension so they can do their ADLs for grasping. Or if they need, the anterior tibialis stimulator during the gait cycle. So with those progressive neurological conditions, John, you have to consider if your immediate goal, so you're using maybe NMES to make gains, or do they need something that is going to ongoing compensate for their loss of strength? Bonnie, in terms of stents, because they're in the carotid artery of the heart, the e-stim I haven't read is going to travel there, but that is likely a patient who has significant cardiac disease. So you have to consider if they have a arrhythmia, it would be contraindicated. And again, consider if you have autonomic stimulation elsewhere in the body, it may stress their cardiac system. Metal implants is not a contraindication for electrical stimulation. Superficial metal is, where the current can conduct. So let's say the patient had surgery and their staples are still in. Or maybe they have shrapnel superficial in their skin. Then electrical stimulation would be contraindicated because it could conduct, takes the path of least resistance. John, Bell's palsy gets complicated because you have to see where they're at in their healing. If you are at the point where there is no active contraction at all, not even a trace, then your assumption is you do not have an intact neuromuscular junction. So you would actually at that time need a low volt EMS stimulation to directly stimulate the muscle. Once the nerve to connection, muscle connection is intact, then alternating current could be beneficial for the patient. Terry, looking at eStim for spasticity, there are a bunch of different studies out, and I was actually, right before I started this morning, I was reading another one on kids with spastic cerebral palsy. That they are finding beneficial effects in terms of decreasing the tone. We again, if you're in neuro rehab, you'll understand this, that certain diagnoses, if we can decrease the tone and restore functional movement or make more gains in functional movement, then the individual can retain that for their activity. But in other conditions, it tends to be a little more progressive, such as someone maybe with multiple sclerosis, or if a child has cerebral palsy, where the condition is going to be ongoing, then eStim isn't necessarily the cure for that, where you're going to do eStim, you relieve the spasticity, and it never comes back. We know with certain diagnoses, individuals across their life are always going to be managing the intensity of their spasticity, so this might be an intervention to help, you know, when you're in that cycle of trying to decrease tone to restore movement, another tool you can utilize. And spasticity is actually another course that I'm developing, so you might want to check back later this year for a deeper discussion on spasticity. I'll have all my research together then. So Emily, I think I hit on the difference between spasm and spasticity, but if you still have a question on that, let me know. Where muscle spasm is a protective reaction of an intact muscle where it's tightening up to limit motion. Spasticity is a neurologic condition where we do not have higher cortical inhibition and it results in high tone. So eStim could be used for both, but in different ways and different reasons. And it's such an important distinction to make. Samantha, with ataxia, you have to consider, and I love neuro rehab too, why does the patient have ataxia and what is your goal and your intention? It's such a huge term and condition. You know, are you working on foot placement and gait? And do they have multiple sclerosis and they're ataxic because they don't have pelvic control, so they don't have good foot placement? Okay, so if it is peds and it's maybe ataxic cerebral palsy, then if you're looking at a condition where it's truly their tone, where the increased spasticity of those adductors is what is causing the ataxia because they can't overcome through their own reciprocal inhibition, then possibly using the electrical stimulation could be beneficial. Now you'd have to work on your pad placement and see if the patient can participate also, depending on their age and their cognitive abilities. Lisa, physiology question, yay. So basically what happens in our nerves is when our nerve is at rest, we have a positive charge on the outside of the membrane, and it's relatively more negative inside. So normally when our brain says, okay, I'm going to, contract my muscle, it initiates depolarization. So our sodium and potassium flip through channels along that nerve to depolarize. When that depolarization gets to the neuromuscular junction, it sends that acetylcholine across that then depolarizes and causes the cascade of events around the muscle fibers to elicit contraction. That's normal. With NMES, specifically alternating current, when you place those electrodes outside and they penetrate down to that nerve, you're artificially doing the same thing, because the positive and negative charge you're inducing from your electrodes is pulling and pushing the ions in the area, and it elicits that same depolarization, if that makes sense, to elicit your contraction. Except it's going to do it a little in a different order. It's going to grab the larger diameter nerves first instead of the smaller. That's why you get those type 2. NMES for lymphedema, that you have to be cautious of, because remember, over an area of malignancy is a contraindication for the application of electrical stimulation. So you would need to look at that patient a little more cautiously with the lymphedema. Also, we're stimulating a muscle contraction because our lymphatic system is traveling in parallel with our circulatory system. We do see increased venous return when we increase circulation, but you also need to be aware that the patient has malignancy, so you do not want to increase the risk of spreading the cancer. So